Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with my dear friend and colleague, Brian Slomovitz, who is at Mount Sinai Medical Center in Miami Beach, Florida, Florida International University as well. Brian, of course, is very well known to all of or most of you for his expertise as a clinical trialist in endometrial cancer. And today we're going to be talking about actually the content of two articles focusing primarily on the latter. But we are going to be speaking about the topics that were published in the Annals of Oncology, the KEYNOTE B21, a randomized double-blind phase 3 study of pembrolizumab or placebo plus adjuvant chemotherapy with or without radiotherapy in patients with newly diagnosed high-risk endometrial cancer. And the focus of this podcast is the published article in JCO, pembrolizumab or placebo plus adjuvant chemotherapy with or without radiotherapy for newly diagnosed high-risk endometrial cancer results in mismatch repair deficient tumors. Brian, welcome, and thank you once again for accepting our invitation to the podcast.
Hey, Pedro, thank you so much for having me. It's it's really an honor and really a pleasure to always have the opportunity to speak with you. And we're super excited about in general, the research we're doing, and being able to report out on studies is exciting. And really, thanks for highlighting the work that we're doing.
Outstanding. Well, Brian, lots of questions that we want to go over, but I was wondering if you can just start by giving us an overview of where we are today as it pertains to the management of patients with advanced or recurrent endometrial cancer. Of course, obviously, there's been quite a number of key trials that really have changed the landscape of the treatment of this disease.
That's a great question. Let me start from the second line setting and then move forward, because I think that's the progression that we're talking here. So we know, first of all, immunotherapy is useful, is effective in all women, all patients with endometrial cancer. And let me explain what I mean by that. So in the second line setting, there were a series of trials that were done. The positive trials, single agent immunotherapy has activity in a biomarker-driven population in those patients with mismatch repair deficiency, microsatellite instability, even a tumor-agnostic indication in those with a high tumor mutational burden. So when we looked at the results of KEYNOTE 158, which was a study with pembrolizumab in the second-line setting, and the GARNET trial, which is a study of dostarlimab in the second-line trial, those two studies were very, very active in patients with second-line recurrent disease. So active, for example, the response rate in the KEYNOTE trial was 48%. We know from GOG3059 in the first line setting, chemotherapy is 52%. So a 48% response rate in the second line setting demonstrated biomarker population, dMMR, immunotherapy works, FDA indications. Now, what about the pMMR tumors in the second line setting? These are the quote unquote cold tumors, and we need to do better. So led by the really great work by Vicky Macker and her colleagues at Sloan Kettering, they looked at the combination of pembrolizumab with lenvatinib, a tyrosine kinase inhibitor, what we like to call a dirty tyrosine kinase inhibitor, meaning several mechanisms of action. And after the initial studies of showing activity, they did a key trial, KEYNOTE 775, which was pembrolizumab, pembro combination with lenvatinib versus investigator choice chemotherapy, which was either adriamycin or weekly paclitaxel, and there was an overall survival advantage. So take that for a moment. Second line immunotherapy, all comers, dMMR, pMMR. That led to a series of 4 trials in the first line setting, looking at the combination of chemotherapy with immunotherapy, checkpoint inhibition, for patients with advanced or recurrent endometrial cancer, first line. GY018 chemotherapy plus minus pembrolizumab, Ruby chemotherapy plus minus dostarlimab, 2OE chemotherapy plus minus durvalumab, and a PARP component with olaparib, and finally the ATTEND trial chemotherapy plus minus atezolizumab. Overall, it was a game-changing results. In the dMMR population, we know that works in the second line, and it works just as well in the first line. Hazard ratios as low as 0.28, meaning that there's a 78% reduction. I'm sorry, 68% reduction in recurrences in those trials. In the pMMR setting, there was also positive results, particularly in the pembrolizumab GY018 and the dostarlimab RUBY trial that led to FDA approval in that setting. So, okay, let's take a pause. FDA approvals in the second line that we talked about, and now the first line. The progression then, well, then let me there was a negative trial looking at pembrolizumab and lenvatinib as a way of getting rid of chemotherapy in the first line. Unfortunately, that was a negative trial. And there's two studies that haven't reported yet in the dMMR setting, single agent pembrolizumab, which I'm the global lead on, and single agent dostarlimab, the Dominica trial. Those haven't read out to see if we get rid of chemotherapy. But those results led us to the idea of, well, if it works in the second line, if it works in the first line, let's see what it does in the adjuvant setting. And that brings us to the subject of today's talk, looking at immunotherapy or pembrolizumab in the adjuvant setting for those patients who are at high risk for recurrent disease.
Excellent. Thank you for that outstanding review of the landscape of where we are as it pertains to these important trials. Now let's talk about a landmark trial, of course, obviously presented at ESMO and published in the Annals of Oncology, KEYNOTE B21. What was the goal in the design of that trial, and what did it show?
So this was a large adjuvant trial. Let me start off saying it had 1,100 patients. Now, we've never done an adjuvant trial of that size, and we didn't just accrue on time, we accrued ahead of schedule. The purpose of this trial, and I'll talk about how we did that in a second, but the purpose of this trial was to look at those patients with high risk for recurrent disease, quickly, non-endometrioid histology with any myometrial invasion in stage 1, endometrioid histology with P53 mutations in stage 1, or any stage 3 or 4 patients, regardless of the histologic subtype. No 3 or 4A patients, no evidence of measurable disease, no evidence of disease, measurable or non-measurable, no evidence of radiologic disease after surgery. The goal was to see if we could duplicate the success of immunotherapy when added to chemotherapy in the adjuvant setting. Now, as an aside, the reason why we're able to accrue so many patients, remember, Pedro, and you and I know this firsthand, when we present these patients at tumor boards at our multidisciplinary clinics, there's usually a radiation bias versus a non-radiation bias. We've really never been able to do these trials because you're either from the camp of radiation or non-radiation. Tough to get agreement, tough to accrue onto 1 or 2 of these trials. In this trial, we left radiation as optional. So whether or not you're a big believer in radiation or not, we allowed the accrual of these patients. So that was really the focus of this trial, to see if, in fact, immunotherapy, in addition to standard treatment, would help patients progression-free survival, overall survival in this population.
Great, and we'll get into those results in a second. But one of the questions also that came up from our fellows was, how is this trial, the KEYNOTE B21, different from trials like PORTEC-3, GY018, the RUBY trial, in terms of like the population?
So the PORTEC-4A trial, and similarly the RAINBOW trial, which are ongoing, looked at all comers with stage 1 disease, and they sort of gave some options outside, some of it like chemosensitizing radiation, but it gave some options for all different types, not just the high intermediate risk types. Now, when we looked at the patients, if you think about it, the patients we're looking at, non-endometrioid histology in stage 1, there's definitely data to support giving systemic chemotherapy to decrease distant disease. And there's definitely data to support in GOG3053 systemic therapy in the stage 3 or 4 patients, regardless of disease or not. So that's the adjuvant setting. Now, GY018, RUBY, those are all patients with, for the most part, measurable disease. RUBY did allow for some patients without measurable disease, but those were the high-risk patients with stage 3C2 or above, para-aortics or above. And as we know, when we get to 3C patients, most of them are positive sentinel nodes in the pelvis. So This was truly a high-risk population, all adjuvant setting, as compared to those other trials.
Excellent. So before we get into the goals of this particular study, if you can explain to our audience a little bit about the difference between an MMR proficient and an MMR deficient tumor, and what are the implications of each?
Yeah, no, thank you for that. And that's really the basis for us for endometrial cancer molecular subclassifications. Now, remember, really great work from the TCGA data. That was published in 2013, a large pan-tumor type of study. Doug Levine, who was at Sloan Kettering at the time, led the GYN arms, demonstrated that when you divided tumors by molecular classifications, endometrial cancer was the easiest to divide into 4 molecular subtypes, really, than any other solid tumor. And the molecular subtypes they identified was POLE, high mutational burden, low mutational burden, or the non-specific molecular profiles, and what we call the dMMR population. dMMR is deficient in mismatch repair proteins. These are shown by MLH1, MSH2, MSH6, and PMS2. If any of these proteins are deficient, then the cells have a decreased ability to repair any damage. About 30 to 40% of endometrial cancers are dMMR. It also is recognized the body as more non-self. And when you think about those tumors that are amenable to immunotherapy, the goal of immunotherapy is to recognize things that shouldn't be there and to get rid of them. Non-self is something that shouldn't be there. pMMR, without those mutations, is recognized by the body as self, right? Something that should be there and is not as sensitive to immunotherapies.
Excellent. So now on this JCO article, you published patients were stratified factors and specifically patients with dMMR category. Tell us specifically about the goals of this study.
Yeah, so quick, just to, as a step back, the large study, the intent to treat population in the large study was a negative trial. Okay, so we learned from that trial that in patients treated with pembrolizumab, regardless of mutational status, that there was no benefit of adding pembrolizumab to chemotherapy. We did have stratification factors, and one of the pre-specified stratification factors was the MMR status, particularly the dMMR status. What we found was the dMMR patients were more responsive, and we needed to explore that deeper in the subsequent presentation that I did at IGCS and the subsequent JCO article, which is obviously the subject here. In patients with dMMR tumors, the addition of pembrolizumab helped to decrease their risk of recurrence by 69%, hazard ratio of 0.31. Now remember, definitely game-changing, unprecedented, similar to hazard ratios we saw in the dMMR population in the first-line setting. When you look at the scheme of things in GYN oncology, these are the numbers we see with PARP inhibitors in BRCA-mutated patients. It works. It's almost something that we need to, it's almost that if we don't offer it, if it's approved by regulatory authorities, if it's approved, it needs to be offered to patients with dMMR mutations. It's almost unethical not to offer it as long as they're sensitive to, as long as they can get, checkpoint inhibitors. So really, we found that the dMMR subgroup pre-specified endpoint, tremendously successful improvement in recurrence rates, PFS.
Excellent. Brian, I want to ask some questions that were submitted by our fellows. The first one is from Ali Strubhar in Salt Lake City. And she asked, in patients with concern for blinded independent central review recurrence, but not investigator, were these patients continued on treatment? Were they unblinded? Tell us a little bit about this for those not familiar with these choices of efficacy evaluation.
Yeah, that's actually a great question. And Pedro, again, as an aside, I want to congratulate you with your fellowship program. You have a really strong group of high-level thinking individuals. So thank you for this question. So The initial evaluation was in the investigator review, and then we did a follow-up BICR analysis. The BICR analysis did not see as much as an improvement as the investigator analysis, but it's biased, right? I mean, the investigator analysis is seeing the patient in front of them. They're evaluating the patient. They know what the lesions look like. They know what they're following. While the BICR review is purely the radiologist. So the patients were continued based on the investigator review. When we look at any discordance or discrepancy between the two, even though some recurrences, quote unquote, were diagnosed on BICR, these patients had stable, quote unquote, stable recurrences without treatment for many, many months, if not years. So the clinical significance of the BICR review can get called into question based on that. If that helps to answer the question.
Yeah, and I just want to clarify for our international listeners, we tend to use lots of acronyms here in the United States. BICR stands for Blinded Independent Central Review.
That's a great. I'm sorry about that to my international colleagues. And the problem is, Pedro, as you know, I'm from New Jersey, so I speak quickly as it is. So I should, and I mumble at times, so I should really focus on my pronunciation. I will work to elucidate very clearly. Thank you for.
We truly appreciate that for us with English as a second language. So myself included. So wanted to ask you the next question comes from Raikan Bolakova. Do you think the results would have been similar if the groups have been additionally randomized by tumor histologic subtypes, endometrioid versus non-endometrioid, regardless of the MMR status, in favor of pembrolizumab?
Yeah, I think that's a great question. Obviously, I don't know the answer, but I think in endometrial cancer, I'm really excited that we're moving away from the more traditional divisions. Histology is important, but I think that, for example, P53 mutational status may be more important. We know, for example, in endometrioid tumors, endometrial tumors P53 wild type behave very different clinically than P53 mutated. The P53 mutated endometrioid tumors probably behave more like the serous, the carcinosarcomas, even the clear cells. So while I think histology is important, and we know what the dMMR rates will be based on different histologies, I do think it's okay to lump tumors by MMR status moving forward, because it really is a good way of delineating. And we know from the PROMISE data, we know from the PORTEC data that those 4 molecular subtypes work to delineate prognostic findings.
So now, you brought this up before, the issue of radiotherapy. Susanna Del Frate from Italy is asking, the decision to include radiotherapy was left to investigator discretion. Could this have influenced the disease-free survival outcomes?
Yeah, it's a great question. I learned from our good friend Anil Sood, the enemy of good is perfect, right? So, which is a saying that I say all the time. We needed to do the trial. In an ideal setting, we'd control for as just any trial, we control for as many factors as we possibly can. We used radiation as a stratification to make sure there was balance between the groups. I don't think it's a limitation of the study. I think it's a strength of the study to allow us to see the performance in different settings. Particularly, as we know, radiation could decrease local recurrences, so we were able to follow distant recurrences as a finding, obviously. But it's a great question.
So as a follow-up to that, this question from Turkey, Mina Dagis, is asking, considering regional differences in radiotherapy quality indicator, was the quality and consistency of radiotherapy assessed to ensure valid comparisons of local recurrence rates between the groups?
Yeah, that's a great question and a great point that the radiation is not the same in all different places. We see that not only in endometrial trials, but in cervical trials as well. That would have made the trial better to have central radiation treatment follow-up. I know that our radiation oncology colleagues are really good at doing multi-site studies and evaluating the techniques and the skill of different centers in getting radiation. We didn't do that in this trial, but we still feel that there was balance in the groups in that perspective.
Yeah. From Spain, Elena Rodriguez Gonzalez is asking, why do you think there was a higher use of pembro for recurrences in the placebo group than in the pembrolizumab group? Could this have had an impact on overall survival observed between the two groups?
Yeah, so we haven't really reported on overall survival, but it's a great question. I think, with the, pembrolizumab is given quite frequently. We know in the recurrent setting that pembrolizumab, as mentioned earlier in our talk today, Pedro, works. So we understand when we look at overall survival, there's always a high risk of crossover. So we suspect when we do look at overall survival down the road, there may be an effect of that. We also know that the use of pembro in those patients who receive pembro is limited, not zero, but limited. There's no data yet on IO after IO or pembro after pembro that deems it to be successful. So while it's used, I don't think that it'll have as much of a benefit than in those patients who are checkpoint naive.
So now getting on to, of course, obviously a topic that we need to discuss is adverse events, side effects. This question from Mina Dagas in Turkey asking, despite similar adverse event profiles between pembro and placebo groups, the discontinuation rates differed significantly, 24% versus 16%, with pembrolizumab itself discontinued in 12% compared to 3% of placebo. What do you attribute this discrepancy to, and did you perform any additional analyses to explore the underlying reasons for this?
Yeah, it's a great question. I mean, whenever you compare something to placebo, one question is why is it 3% with placebo, right? I mean, it's placebo's placebo, but there's always somatic effects of drug transfusions and things like that. Yes, pembrolizumab has a side effect profile. I think the 12% is aligned with, or maybe a little bit higher, but aligned with the rate of discontinuation rate even outside of clinical trials. So I think that we need to consider looking at it. I really can't delve into follow-up studies that we're doing. A lot of that's what Merck's planning on, and where we haven't really started anything yet. I can say that for a variety of reasons, but yeah, it's a good point, and we have to, we're continue to constantly look at discontinue rates, but it is a lot lower than, for example, pembro in combination with lenvatinib.
So this is an interesting question also from one of our fellows, and she's asking, can it be considered that for patients with endometrial cancer with lymph node involvement, the use of pembrolizumab is more beneficial?
Yeah, the question is should we just be using this in the stage 3 setting, or should we be using it in stage 1 to 3 setting? We know that it works in this patient population, the ITT population. We know that other pre-specified, we know that this is studied in the ITT population. I think we do need to do further evaluations in the high stage patients to see, similar to dMMR, if there's a benefit in those populations. Based on the data, without diving too much, there's perhaps some suggestion of that. But again, we need to, this is just the tip of the iceberg in the evaluations that we're presenting. So we need to do more to evaluate those. And I love it. Your fellows are really trying to get some information out of me that's not yet reported. So they've learned from the best. But, I feel like I'm getting, yes, Your Honor. No, I love the interview. But we just don't have the data yet. And it'll be interesting to see how that plays out.
Probing. So this next question comes from Jose Vilches in Malaga, Spain. And he's interested about the impact on tumor burden. So he's asking, given that tumor burden may be an important factor in the efficacy of pembrolizumab, do you think it could be an effective treatment for tumors that you just cannot completely resect?
That's a brilliant question. And that's one of the things we looked at, we first evaluated and thought about when we had a negative trial. So in the dMMR tumors, perhaps you don't need any tumor. It's a hot tumor, even with the cells, to elicit a response. However, in the pMMR tumors, perhaps you do need a higher neoantigen load, as seen in GY018, as seen in Ruby, that will help the immunotherapy work better. So one explanation for that is spot on, exactly what the question is. Maybe the lack of macroscopic disease in this population contributed to the lack of efficacy that we've seen in the pMMR population.
Now, Elena Rodriguez, again from Spain, she asks, what would be your recommendation regarding the use of pembrolizumab as adjuvant treatment in advanced stage endometrial cancer after R0 surgery and presenting with a molecular profile with P53 mutation and dMMR?
It's a great question. I think let's talk about the answer outside of regulatory approval because we don't know if it's available or not. But based on this data and based on the fact that there's no good adjuvant data available in the pMMR mutated setting, but this is dMMR, if it's available, I would give pembrolizumab. Now, if it's available, I'd give pembrolizumab. And because, I mean, a hazard ratio of 0.31 is tough to beat. But, I wouldn't use the P53 mutation as a reason why not to give it.
So going back to GY018, NRG GY018, Roberta Massobrio from Italy is asking, in that study, the addition of pembrolizumab to chemotherapy in first-line setting showed benefits in both dMMR and pMMR populations. How do you explain the different results observed in the pMMR patients in the adjuvant setting?
And so this is based on the GY018, why it was positive and why is this negative?
Mm-hmm.
Yeah, that's a great question. And I think, similar to what I said, maybe it's a lack of macroscopic disease and not enough neoantigens that resulted in a negative trial here and a positive trial there. We're still waiting for some more molecular classification data in the in the GY018 trial that'll help elucidate further if there are subgroups that benefit and subgroups that don't benefit, and then do cross-trial comparisons, which we can't always do, to figure out how that plays out. But we'll have to see.
Then Brian, just a few more questions. Do you see a potential? This is one of the questions from Roberta Massobrio. Do you see a potential for avoiding adjuvant chemotherapy in favor of just immunotherapy for high-risk dMMR patients?
Yeah, that's another. I mean, it's really great questions. So we know in the metastatic setting in colon cancer that checkpoints in the dMMR setting, checkpoint inhibitors work versus chemotherapy. That's on KEYNOTE 177, colorectal cancer. As I mentioned, there's two trials evaluating it. KEYNOTE C93, GOG3064, which I'm the PI of, looking at the dMMR population, advanced to recurrent disease, if chemotherapy can work better than chemotherapy. And we're doing something similar with the Dominica trial with dostarlimab. If those trials are positive, I think we will sort of, the term, borrow that information into the adjuvant population to give patients with dMMR tumors that are highest for recurrence checkpoint inhibitors alone and not the chemotherapy. But again, there's some assumptions there, and we don't have that data to support that fully yet. But I would love to as you know, Pedro, one of my goals is to get rid of chemotherapy for this disease. I would love for that to happen.
Yeah. So Brian, of course, as a last question, I often ask the authors and guests of the podcast, how have the results published in JCO and Annals of Oncology of KEYNOTE B21 study impacted your discussion in the management of your own patients, and how do you move forward from here in terms of incorporating these findings into your everyday clinical practice?
Yeah, no, and again, thanks for the opportunity to comment this. I think in all-comer population, particularly the pMMR setting, I'm not going to be quick to jump into the use of pembrolizumab in this setting. That being said, if you know it's a POLE mutation, remember those are microsatellite stable, I would consider using it based on this data. Now, in the dMMR setting, given the hazard ratio of 0.31, relatively tolerable regimen, if it's available, I would use it today, if it's available. And that's me in my practice. No one's telling me to do that. That's Brian Slomovitz's independent review. I don't want you to think I'm representing anyone or any entity in that comment. But we have to see if there's, regulatory strategies moving forward. I'm not sure. And if it is regulatory approved, then it'll be a lot different. But yeah, I think it's game changing. I mean, this is pretty powerful numbers.
Outstanding. Well, Brian, thank you so much once again for accepting our invitation. always enjoy hearing from you on this very important topic on the management of patients with endometrial cancer. Always learn a tremendous amount from your expertise and your wisdom. I also want to thank you again for the contributions you continue to make to the field of gynecologic oncology. Extremely proud of having been part of your professional development when you were a fellow with me at MD Anderson. Thank you so much.
Thank you, Pedro. And again, thanks for having me. And I look forward to our continued working relationship. And congratulations on your, really you're a phenomenal editor and you really turned that journal around. So congratulations there as well.
Thank you.